Welcome to Final BDS Made Easy. Classify potentially malignant disorders and describe OSMF in detail. It is one of the important 7-marker questions in the subject of oral medicine. Starting with the classification, oral potentially malignant disorders include erythroplakia, erythroleukoplakia, leukoplakia, OSMF, disc keratosis congenita, smokeless tobacco keratosis, palatal lesions associated with reverse smoking, chronic candidiasis, lichen planus, discoid lupus erythematosus, syphilitic glossitis, and actinic cheilitis. Detailed description of OSMF, starting with the definition. It was given by Pinbog and Sirsat in 1966. It is an insidious chronic disease affecting any part of the oral cavity and sometimes the pharynx, although occasionally preceded by and or associated with vesicle formation. It is always associated with juxtaepithelial inflammatory reaction followed by fibroelastic changes of the lamina propria with epithelial atrophy leading to stiffness of the oral mucosa and causing trismus and inability to eat. Various causes for OSMF like chilies in which capsaicin is an active ingredient and a potential irritant. Tobacco is also a known irritant and causative factor for oral malignancy. Lime, when used with betel nut, it causes local irritation and damage to the mucosa. Betel nut contains ericolin and other alkaloids which stimulate fibroblast proliferation and collagen synthesis leading to fibrosis. Nutritional deficiency. Deficiencies, especially in vitamin B complex, could be precipitated by impaired nutrition due to the disease. Defective iron metabolism. Microcytic hypochromic anemia with high serum iron has been reported. Bacterial infection, streptococcal toxicity, and Klebsiella rhinoscleromatis may play a role. Collagen disorders linked to localized collagen diseases such as scleroderma and rheumatoid arthritis. Immunological disorders, raised erythrocyte sedimentation rate and globulin levels indicate an immunodeficiency disorder. Altered salivary composition. Changes in saliva composition have been observed in OSMF cases. And last one is genetic susceptibility. Familial occurrence has been reported. To the etiopathogenesis, there are two processes that occur simultaneously. There is increased collagen synthesis and decreased collagen degradation. Areca nut induces inflammation and increases profibrotic cytokines like TGF-beta, activating collagen genes and the collagen production pathway. Flavonoids increase collagen synthesis, resulting in increased soluble and insoluble collagen. Areca nut also activates tissue inhibitors of metalloproteinases and plasminogen activator inhibitor, inhibiting collagenase enzyme. Flavonoids and copper activate lysyl oxidase, increasing the cross-linking and stabilizing the collagen structure. Coming to the clinical features, it affects both sexes, mainly between 20 and 40 years. It commonly affects the buccal mucosa, retromolar areas, soft palate, facial pillars, uvula, tongue, labial mucosa, floor of the mouth, and gingiva. Prodromal symptoms are burning sensation, hypersalivation or dryness, vesiculation, ulceration, pigmentation, recurrent stomatitis, and defective gustatory sensation. Late symptoms are trismus, difficulty in tongue protrusion, swallowing difficulty, referred pain, and nasal voice. There is blanching of mucosa due to impairment of local vascularity, which makes it opaque, white, and marble-like. There is also something called beetle chewer mucosa, which shows an irregular surface with brownish red discoloration. Fibrous bands become palpable, which are vertical bands which appear as the mucosa stiffens. Then lip features include circular bands around the rima oris, altering the mouth opening to an elliptical shape. Buccal mucosa becomes coarse, blanched, and inelastic with numerous vertical fibrous bands. Soft palate and uvula show fibrotic changes and restricted mobility. The uvula may become bud-like or hockey stick shaped. Then palatal fosses show fibrotic bands radiating from the pterygomandibular raphe, causing tonsillar compression. Tongue shows deep appellation, smooth appearance, and impaired mobility. Floor of the mouth and gingiva become inelastic and fibrotic. Associated features are hyperpigmentation, vesicles, ulceration, and petechiae. OSMF can be graded according to the Keretal classification. Grade 1 includes features for mild OSMF. Any features of the disease triad, including burning, deep appellation, and blanching or leathery mucosa, may be reported, and the interincisal opening is more than 35 mm. Then grade 2, in which there is above features plus interincisal limitation of opening ranging from 20 to 35 millimeters. Grade 3, severe form of OSMF, in which above features are seen plus the interincisal opening is less than 20 millimeters. Grade 4A, in which there is OSMF plus other potentially malignant disorder on clinical examination. Grade 4B, in which there is OSMF with any grade of oral epithelial dysplasia on biopsy. Grade 5, in which there is OSMF plus oral squamous cell carcinoma. Now coming to the diagnosis, it can be made clinically where reduced mouth opening and palpable fibrous bands are indicative, and laboratory diagnosis shows atrophic oral epithelium with intercellular edema, signet cells, epithelial atypia, and mononuclear inflammatory cells. Biopsy is the gold standard for diagnosis. Other tests that can be done are CBC, iron levels, and B12 and folate levels. Differential diagnosis includes scleroderma, fibroma, generalized fibromatosis, anemia, and amyloidosis. The summarization for the management of OSMF by Ongol. Stage 1 includes systemic management with iron supplements and antioxidant capsules twice a day for 3 months. Then topical management with benzidamine rinse, 0.15% mouth rinse. Then triamcinolone gel, a commercial name for which is TESS, or crushed dexamethasone tablets in 20 milliliters of water and used as mouth rinse. Then immunomodulators such as levamisole, 150 milligrams once a day for 3 days, twice in a month for 3 months. Newer drugs are available such as pentoxifylline, 400 milligrams twice a day for 15 days, and interferon gamma injections. Stage 2 and 3 treatment includes intralesional injections of dexamethasone plus hyaluronidase, 1500 international units plus lignocaine 2 milliliters, multiple site injections once a week for 6 weeks. Then betamethasone plus hyaluronidase, 1500 international units plus lignocaine plus placentrex, 3 milliliters, multiple site injections once a week for 6 weeks. And in stage 4, no medicinal treatment can be given. Surgical relieving of fibrous bands with buccal pad of fat and covering the wound is one of the treatment plan, and next is laser surgery. Physiotherapy can be done in stage 2, 3 and 4 using mouth opening exercises, ice cream sticks, mouth opening appliances, and ultrasound. Here's the management in more detail. First step is habit cessation or behavioral therapy. The preventive measure should be the cessation of the habit, which can be encouraged through public education. Affected patients should be educated about the disease and its possible malignant potential. Improvement in clinical features such as the gradual increase in interincisal opening has been observed in most patients who discontinue the habit. Next step is medicinal therapy. Supportive treatment should be given with vitamin-rich diet along with iron preparation. It is helpful to some extent but has little therapeutic value in relieving trismus. Then iodine B complex preparation. Intramuscular injection starts with small doses and continues with larger doses, 2 milliliters ampule daily. The course of 5 injections is repeated after 7 days. The preparation stimulates metabolic processes and enzymatic processes within the body. Injection of arsinotyphoid and iodine. Arsinotyphoid acts as a fibrin dissolving agent. Third step of management is steroids. Locally, hydrocortisone injection along with procaine hydrochloride injection is given in the area of fibrosis. Injections are given fortnightly and early cases show good improvement with this therapy. Systemic administration of hydrocortisone 25 mg tablet in doses of 100 mg per day is useful in relieving burning sensation without untoward effects. Triamcinolone or 90 mg of dexamethasone can be given supplemented with local injection of hydrocortisone 25 mg 2 times a week at the affected site. This increases vascularity and prevents fibrosis by decreasing fibroblastic production and deposition of collagen. Fourth step is placental extract. It acts as a biogenic stimulator, stimulating the pituitary adrenal cortex and regulating tissue metabolism. It increases tissue vascularity and aids in metabolic or regenerative processes. Placental extract can be separated into aqueous extract, lipid extract, immune gamma globulin, and tissue coagulated. The affected region is injected with 2 milliliter solution every 3 days for 15 days. The course can be repeated after a month if required. Next is administration of hyaluronidase. By breaking down hyaluronic acid, it lowers the viscosity of intracellular cement substance, decreasing cell formation and improving the health of mucous membranes, burning sensation, and trismus. Next is lycopene. It is an antioxidant from tomato extract along with other antioxidants. Tablet lycopene 2000 milligrams for a period of 3 months with re-examination should be given every 15 days. Next is vitamin E. It works by preventing the oxidation of essential cellular constituents, protecting against various drugs, metals, and chemicals, and acting as a scavenger of free radicals. It may improve the survival of erythrocytes. Other therapies are vasodilator injection. They relieve the ischemic effect and help therapeutic measures reach the affected tissue. Injection of interferon gamma, which is a recently discovered therapy. Intralesional injection improves mouth opening and reduces mucosal burning. Next is pentoxifylline. It improves mouth opening, tongue movements, and fibrotic bands when given at a dose of 400 milligrams 3 times daily. Next is the surgical treatment, including the conventional treatment. And surgical treatment is chosen when there is marked limitation of mouth opening and neoplastic changes in biopsy or marked trismus and dysphagia. Here, flap is used as a graft. The fibrous bands are excised, followed by tongue flap graft or nasolabial flap or bilateral palatal flap. Also, implantation of fresh human placenta can be done. Submucosal implantation following the surgical excision of fibrous bands. Carbon dioxide laser surgery incises the buccal mucosa and vaporizes submucosal connective tissue. And cryosurgery can be done. Oral physiotherapy includes mouth opening and ballooning of the mouth to put pressure on the fibrous bands. Forceful mouth opening with mouth gag and acrylic surgical screw can be used. Microwave diathermy is useful in early or moderately advanced stages, acting by physiofibrinolysis of bands. Combined with other treatment modalities, its value is increased. That's it. Thank you for watching. Do hit the like button, share with your friends, and subscribe to my YouTube channel. Stay tuned.